In this video, we present two cases of endoscopic ultrasound-guided treatment of varices when not visualized in direct endoscopy. A linear echo endoscope, 19-gauge access needle, coil, and absorbable gelatin sponge are required for the procedure. In our first case, we have a 62-year-old female with alcohol-related decompensated cirrhosis who was transferred from outside hospital with recurrent upper GI bleeding. She had medium-sized isolated gastric fundal varices that were treated with prior cyanoacrylate glue injection using direct endoscopic view. An urgent upper endoscopy showed glue cast ulcer without obvious gastric varices to guide treatment. So a decision was made to pursue with EUS. EUS showed few tubal anechoic structures in the submucosal layer which were consistent with varices. The penetrating varix that feeds the entire variceal system is identified as the target varix. This varix is seen closer to the lumen. It measured about 6 mm in cross-sectional diameter. The coil size is typically selected such that it is 30% larger than the variceal diameter. The size of the needle is determined based on the end hole diameter of the coil. In our case, a 0.035-inch coil was selected, hence 19-gauge access needle was used. Gelatin sponge slurry is prepared at the beginning of the procedure by cutting gelatin sponge into small pieces and mixing them with normal saline. The needle is then advanced to puncture the varix with return of blood confirming needle placement into the vessel. Coils are front-loaded using the stylet and deployed into the vessel, followed by injection of 8 milliliters of gelatin sponge slurry. Doppler post-treatment showed decrease in the flow of the treated varix and of the deeper varices. No post-procedure adverse events such as pain, bleeding, or embolization were noted. Following hemostasis with EUS, she underwent successful CHIPS. No recurrence of bleeding was noted. Our second case is a 63-year-old male with decompensated alcohol-related liver cirrhosis who presented to our hospital with recurrent lower GI bleeding. In his prior episode of GI bleeding, flexible sigmoidoscopy showed non-bleeding rectal varices which were treated with cyanoacrylate glue injection. He was deemed not a suitable candidate for CHIPS. In this admission, flexible sigmoidoscopy showed few non-bleeding blue cast rectal ulcers. No varices were seen. EUS showed a penetrating varix of 5 mm by 15 mm in diameter. A 0.035 by 10 cm by 14 mm embolization coil was deployed into the varix, followed by injection of 4 milliliters gelatin sponge slurry. This led to eradication of the varices. Surveillance endoscopy in 2 weeks showed decompression of rectal varices with no audible Doppler flow. No further recurrence of bleeding was noted. Gelatin sponge is a water-soluble hemostatic device that forms a plug by absorbing blood 45 times its weight. Coils promote clot formation and serve as an anchor to the gelatin sponge, preventing systemic embolization. In the largest case series reported by Basabashi, no immediate procedure-related complications were reported except for one case of abdominal pain which was treated conservatively. In our cases, EUS could identify varices when they were not seen endoscopically. In line with our finding, BIC reported that EUS could identify and treat a significantly high number of gastric varices compared to direct endoscopy. Additionally, fewer number of coils were used in our study compared to the literature. This is likely from targeting the penetrating varix, which led to the decompression of the entire variceal system. In conclusion, Visualization of varices under direct endoscopy can be difficult in some clinical scenarios, making treatment challenging. EUS is a modality that can identify varices and guide treatment.